Good morning, everyone, and welcome to the Myocarditis Foundation Zoom call family meeting. We'd like to thank you all for taking time from your Saturday to be here with us. This meeting has been made possible by our three sponsors: Canixa Pharmaceuticals, the Kennan family, and the Trilogy Group at Morgan Stanley. I apologize for any technical difficulties, such as what we had prior to signing in and also now, because Melissa, I can't get to my thing. Okay, there it goes. Okay. What is this? Okay, sorry, we're not perfect on these Zoom calls. These three companies and families have chosen to support our meeting because they believe that all patients should have access to medical experts in the field and up-to-date information on myocarditis and pericarditis. I'd like to introduce and tell you a little bit about myself, but first I want to just give a little disclaimer that I'm babysitting my grand puppy, and I'm hoping he will be quiet. My husband has him in his office. But I apologize ahead of time for that. And anybody who wanted to get in, if you could tell them that this will be recorded and put on our YouTube channel in a couple of days, that would be great. Okay, for those of you who don't know me, my name is Genevieve Ramori. I've been the executive director for the Myocarditis Foundation for the past 6 years. I am a registered nurse with more than 45 years of experience. Many of those years were in cardiac and emergency room nursing. And I have personal experience dealing with myocarditis and the side effects that it can cause, up to and including heart transplantation. Today is our third virtual family meeting this year, and we have an ever-increasing number of participants. Perhaps this is one positive outcome of the COVID-19 virus, the awareness and popularity of virtual meetings, allowing us to get together with people around the world to discuss myocarditis and pericarditis, two rare diseases that often go hand in hand. Hopefully, we will be able to get back to our in-person family meetings sometime soon. Today, we have participants from 6 countries joining us. We hope that you are comfortable and have your morning or afternoon beverage of choice with you, depending on what area of the world you're calling in from, as you listen to our esteemed cardiologists and researchers respond to the questions that you have sent in. I do need to remind you that this cannot be a personal consultation of sorts. The doctors will try their best to give you as much information as they can without getting specific to each of your cases. We ask that you wait for the last 30 minutes or so of the meeting before asking any additional questions that you may have on the chat screen. Your question may already have been answered throughout the discussions. We will attempt to answer as many of your questions as we can. I would like to take this time to announce our esteemed panel of cardiologists and researchers, many who are on our board of directors and medical advisory board. Dr. Leslie Cooper is the co-founder of the Myocarditis Foundation. And I lost my screen again. Yeah, I did. Okay. I'm sorry. He's the chair of the Department of Cardiovascular Medicine at the Mayo Clinic in Florida. He's a doctor of internal medicine with a specialty in cardiology, heart failure, and transplantation. He's world-renowned in the field of myocarditis and giant cell myocarditis, a professor of medicine at the Mayo Clinic College of Medicine. He has numerous awards. He participates in professional memberships, too many for me to make note of, societies, editorial boards, scientific committees. He's a very busy gentleman. Dr. Wilson Tang, also another very busy gentleman, doctor of internal medicine who specializes in cardiology, especially heart failure and cardiac transplantation medicine at the Cleveland Clinic. He's the director of the cardiomyopathy program at the Cleveland Clinic and also for the Center of Clinical Genomics and Clinical Research at Cleveland Clinic. He's a professor of medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. He's the principal investigator for the Myocarditis Foundation Biobank, and he too has been awarded numerous awards. He's participating in many professional societies, on editorial boards, in scientific committees. Another very busy doctor. Dr. Allan Klein, also another very busy man, and I appreciate all of you coming to help us out today. He's a cardiologist also at the Cleveland Clinic with specialty interests in cardiovascular imaging, echocardiography, cardiac MRI, and computed tomography. He's the director of the Center for the Diagnosis and Treatment of Pericardial Diseases at the Cleveland Clinic, a professor of medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. He's past president and current member of the American Society of Echocardiography and author of a book on clinical echocardiography, which is used by many today. Again, a very accomplished cardiologist. Dr. Justin Godown, he's a director of pediatric medicine and board certified in pediatric cardiology. He is also on our medical advisory board. He's the medical director of pediatric cardiomyopathy and pediatric cardio-oncology at Vanderbilt University, Monroe Carell Jr. Children's Hospital. He's an assistant professor in the Department of Pediatrics there and the Division of Pediatric Cardiology, Vanderbilt University, Monroe Carell Jr. Children's Hospital. He's a member of numerous professional organizations. He's an author and journal reviewer for many professional publications. Now for our researchers. Dr. DeLisa Fairweather, not that these other gentlemen don't research, they do, but Dr. DeLisa Fairweather has been studying viral myocarditis for over 25 years, beginning when she was a PhD student at the University of Western Australia. She developed a new animal model of Coxsackie myocarditis as a postdoctoral fellow at Johns Hopkins School of Medicine, where she discovered the importance of the innate immune response in causing disease, that males had worse disease. I didn't read that correctly. She discovered the importance of the innate immune response in causing disease and that males had worse disease. She moved from a tenured faculty position at the Johns Hopkins Bloomberg School of Public Health to direct translational research at Mayo Clinic in Florida, where she is examining the role of mitochondria and extracellular vesicles in viral myocarditis and COVID-19. We love to hear of new myocarditis researchers, and we have one with us today. Damian DeFlorio is a PhD candidate at the Mayo Clinic in the laboratory of Dr. DeLisa Fairweather. Damian began his research career at the Pennsylvania State College of Medicine, where he worked as a research student for 3 years before joining Mayo's PhD program in 2018. His primary research interest is understanding how sex differences in mitochondria in the heart can influence the immune response during myocarditis. He hopes that understanding these processes will provide information for the creation of novel diagnostic tools and therapeutic targets specific for viral myocarditis. I'd like to give you a quick thank you again to the doctors and research for helping us today with your expertise and knowledge of these diseases. Now let's get started with the questions that you have sent in. Doctors, while I will be addressing certain questions to specific panel members, please feel free to add any additional information that you may have to the answers that will be provided. Dr. Godown, as the pediatric cardiologist on our panel, we've had some questions by parents concerning pediatric myocarditis. While most children recover without complications, there was a question about cardiomyopathy post-myocarditis. Could you explain a little bit about post-myocarditis cardiomyopathy and heart failure in children, please?
Sure. So thanks, Jen. So clearly, when children develop myocarditis, a decent percentage actually recover and will recover ventricular function. However, the heart presumably sustains some damage during the process. And so some children actually will go on to develop a more chronic cardiomyopathy. Each case is very different, and there's a lot of things that go into kind of which patients might develop problems. But after cardiomyopathy develops, basically we end up treating it like heart failure. So it's kind of standard heart failure regimen. And presumably that's due to the damage that occurred during the myocarditis episode. Was there any more specific kind of questions about the cardiomyopathy?
No, there wasn't, except that would you recommend post-myocarditis? What exercises would you recommend post-myocarditis? And if a child is on a beta blocker, and that would be, I guess, for cardiomyopathy.
So exercise is really going to be patient dependent. It depends on the recovery of heart function and the cardiovascular status of the patient. It's also going to depend on the time frame since the myocarditis diagnosis. In general, I usually restrict people from strenuous activity for about 6 months after the acute episode. If they have recovered function, many times I will do a treadmill test at that point, and if that looks reassuring and overall they're doing well, many times I will not restrict them from activities. That being said, if someone has a lot of residual cardiac disease or ventricular dysfunction, that recommendation certainly might change. In terms of the question on beta blocker therapy, so sometimes we do use beta blocker therapies for heart failure management. I would not necessarily think that's going to impact our exercise recommendations, but certainly could impact the patient's ability to mount a heart rate response when they are exercising.
Thank you. Thank you very much. Now, if we have a few people who have had a number of children, actually 2 children, that one had passed away from myocarditis and the other one survived it. If there is a sibling of a child who died of viral myocarditis, are they more susceptible to developing myocarditis from, say, COVID or another virus?
That is a fantastic question. And I think it's a really difficult question to answer. So certainly there could be some genetic predisposition where some people are more at risk for developing myocarditis. But for the most part, myocarditis is still a rare diagnosis. And so it's hard to say that because one child had myocarditis that the others at significantly higher risk. I think that's probably not the case. And to have 2 children, now remind me the context, were 2 children have myocarditis?
Yes, one passed away, and then I think a couple of years later, another child developed it but survived.
Yeah, I mean, that certainly makes you wonder if there's some genetic predisposition. But I think we still have a lot of research to do and work to do to further understand that.
Yes. And speaking of not knowing the cause often, if there is no known specific cause for, say, someone's case of myocarditis, and they did genetic testing and search for viruses, came back inconclusive, and even the cardiac biopsy just showed fibrosis, is there any benefit to looking further for a cause? And if so, how, what?
So again, it depends on the specific scenario and how the patient presented. Many times we don't find an etiology for myocarditis, and we have to presume that the diagnosis with myocarditis based on the presentation and just the details surrounding the case. Even when we do kind of PCR testing on the myocardial biopsy, sometimes we don't even find a virus, but many times it's presumed to be kind of a viral etiology. The same thing goes for kind of dilated cardiomyopathy. So you said they said genetic testing. So typically we would do that if we're thinking about a kind of familial cardiomyopathy. And sometimes, even though clearly there's a cardiomyopathy running through some families, sometimes we don't actually find the genetic basis for that. And whether that means there's multiple genes involved or we're just not smart enough yet to figure it out, many times we actually don't know the exact etiology for some of these things.
Thank you very much, Dr. Godown, for that information. We really appreciate it. Now we're going to move on to some questions about pericarditis. We have 6 people on our call today with pericarditis. Dr. Klein, since you are the pericarditis specialist on today's call, I will address these questions to you. However, any of our panelists are welcome to add their thoughts on this topic. Pericarditis is a form of inflammatory heart disease. For those of you who don't have pericarditis and maybe are not familiar with it, it is inflammation of the pericardium, or the outside layer of the heart. What are the causes of pericarditis, Dr. Klein? And once you've had it, are you more prone to getting it again?
Specialist. So I'm the lone pericardial guru on the call. So first of all, Depends where you live. If you live in a Western country like USA or Canada, the most common cause would be idiopathic or viral. So viral is assumed. Sometimes you don't know the cause. If you live in India or China or Russia, TB would be the most common cause. So it really depends where you live. But in the US, I would say idiopathic or viral. Then another leading cause of pericarditis would be post-cardiac injury. So as patients get procedures like afibrillation, I'll pick on electrophysiologists, pacemakers, or interventional cardiologists that do PCI and they perforate. Any blood in the pericardium is a big irritant. So that's another leading cause, or even post-cardiac surgery. You have valve surgery or aorta surgery. You get a Dressler syndrome after that surgery. And then other causes could be autoimmune. Most common would be lupus or rheumatoid arthritis, Sjogren's syndrome. And finally, neoplastic cancer can cause pericarditis. But in general, the bulk of our practice would be idiopathic or viral or post-cardiac injury. If you, second part of the question, if you get the first episode, you get a viral illness and you get acute pericarditis, which means pericarditis within 3 months, there's almost a 15 to 30% chance, a third chance to get a recurrence. If you get it once, there's a 50% chance you're going to get it again. So it's incremental going from the first episode.
Is pericarditis easily treated?
Oh, definitely. In the US, in my experience, it's easily treated, but poorly treated. So that's why there's centers, for example, in Cleveland, Mayo Clinic, to name a few, that sort of specialize in pericarditis. So there is standard protocols. So just going through the algorithm, there's a stepwise approach. So if you have acute pericarditis, that means active pericarditis within 3 months. The most common treatment, the first line treatment, will be NSAID and colchicine and exercise restrictions. So basically, NSAID, what I mean by that, good old Aleve, ibuprofen, aspirin in older people, and then colchicine, which is used to treat gout, is used. So that combination, dual therapy. And then we tell our patients sort of the cooling on the exercise because the active exercise could aggravate things. If you fail that, you go to second line. And the most common cause for second line would be low-dose prednisone. Now, prednisone has a bad rap because when you give prednisone, often in emergency rooms, they give you a short course. They give you a Medrol dose pack, and that will reactivate the pericarditis. So that's like a no-no. So if you have a very bad case and you have to go on prednisone, you go on what you call triple therapy, the NSAID and colchicine, plus the prednisone. Then you have third line. So you have a very resistant case, and then you go on to the drugs that rheumatologists give. For example, Imuran or methotrexate, and now more recently these biologics, anakinra or rilonacept. And fourth line, at places like Cleveland and Mayo, we often offer pericardiectomy to remove the lining. So it's quite simple. It's basically 4 levels of treatment. I should say that the biologics like rilonacept have been proven recently in a trial that I was involved with called the Rhapsody trial. And that showed that you could, is very, very effective. And perhaps you can avoid the steroids. It was given for patients that were sort of stuck on the colchicine, stuck on the prednisone, they couldn't get off in very resistant cases. And the biologic rilonacept was very, very useful. So in addition to that, we do have advanced imaging that guides the therapy. So we've, and others have pioneered the role of advanced imaging to sort of prognosticate. So in other words, if we see somebody with acute or recurrent pericarditis, from your baseline MRI, we can predict how many drugs, how many years, how long to taper, the likelihood of going on biologic. So we've really refined the therapy using this imaging guided approach.
Wow, that's very interesting. We have a question from a pericarditis patient, Arcalyst, which is the brand name for rilonacept. It is a new drug for recurrent pericarditis. And this patient is on it and was asking, in the studies of the drug, has anyone been successfully weaned off Arcalyst or rilonacept since it's been on the market? I know it's only been out a couple of months, I believe.
Okay, so let me just go briefly. So we did the Rhapsody trial with Arcalyst or rilonacept. And prior to that, we did a pilot study. Now, in the pilot study, which was done, people did come off rilonacept. So we do have a little experience. A few people did recur, and a lot of people did not recur after coming off. In the Rhapsody trial, we're still studying the extension period. We're still studying the extension, so we don't know exactly. In my experience, I know if you can sort of base it on anakinra, which is another biologic, there are some people that have a tough time coming off. So we don't really know yet how long you have to be on it. Basically, in the trial, people were on it roughly a year in the trial, but there is an extension period, and we're using MRI often to guide how, if it's successfully being treated. But if you have a bad case of pericarditis, recurrent pericarditis in particular, and in my experience, very bad MRI, meaning, very intense uptake, it's going to be a long time before you can get off those drugs. That's my experience. So we don't know yet. We hope that drugs like rilonacept, which has a longer half-life than anakinra, would be able to sort of to lower the incidence of recurrence, but we don't know yet.
Thank you very much.
Jen, I have I don't know if you have more questions for him first, but I have comments also.
Sure, go ahead. I have more questions, but feel free, DeLisa, Dr. Fairweather, go right ahead. We'd love to hear you.
So from a research standpoint, we have some input about what we found in an animal model of Coxsackie virus myocarditis. And in this case, we always see pericardial, it's like perimyocarditis. So we see pericarditis and myocarditis together. And pericarditis with the inflammation being on the outside. In many cases, we think that in this model that it starts sort of from the outside and moves in, but it also can come in, inflammation comes in from the vessels. And one of the key things that we found that's important in those locations is a cell called a mast cell, MAST. So those are what we think of normally as allergy cells. But in the context of myocarditis, it's not your typical allergies. It's not IgE mediated response. Mast cells can actually do lots of other things, and they're important. They have important relationship to antibody levels, and also part of antibodies is something called IgG rather than IgE. So there are two different types of antibodies. So they're really important in kind of what we think as a regular immune response rather than a typical allergy response. And we see that the mast cells are located. There's a lot in certain strains of animals. There's a lot of mast cells on the pericardium. And there's also a lot of mast cells right where the blood goes into the heart, where there are vessels. And so those are two places where inflammation comes in after a viral infection into those locations. And some of the important things that we found, even as he was mentioning about colchicine, which is important for gout, I think some of the things that have been found that medication does is decreases a cytokine called interleukin beta. And that cytokine we found is really important. It's released from mast cells. It's really important in driving fibrosis, remodeling that happens with the pericarditis, and also in the heart. And that also is associated with leading to dilated cardiomyopathy. So if you have, in the animal model, if you have activation of mast cells on the pericardium, you also have them in the interior of the heart. and it leads to remodeling, then this is a really important factor in whether this is going to then help to promote going to dilated cardiomyopathy later. And it's another important part of this is we also can see in certain situations that what's called immune complexes can really lay down on the outside of the heart, making the pericarditis worse. It's probably part of the factors why many of these drugs that Dr. Klein just mentioned would be very good at helping to reduce these types of responses. So we really see a parallel with what has been described clinically with what we see in the animal model, where we're really trying to understand some of the mechanisms, some of the details of what the immune response is doing that drive both these acute responses and understanding better how it can progress to disease later on.
You know, DeLisa, that's for everyone on the line, I just emphasize how important what you said is to understanding the different forms of myocarditis. For those who are not in the medical field or the research field, we think of myocarditis as a single thing, perhaps, but it's many different diseases. And the IL-4 mast cell eosinophil flavor of myocarditis is different than perhaps than the IL-17, which is interleukin 17, GM-CSF fibrosing flavor. These are different cytokines I'm describing. They're different patterns of inflammation. But it's important to realize that in the future, rather than describe myocarditis just by a particular cell or a particular pattern of inflammation, it's going to be more personalized, more individual. And our hope is that this foundation and the work that we're doing through our researchers, we're going to hear more about that shortly, will help lead to new treatments that are personalized and less toxic.
Yes.
Thank you.
If I can say something, Lisa, that's very fascinating for this. Do you think people are looking at neutrophil over lymphocyte ratios? You think, or should we be measuring eosinophils in pericarditis? Is there something that we could look into that?
I think the mast cell has been really overlooked. And of course, that's more difficult to look at, but I think that cell is the most important. The mast cell is critically important in activating the eosinophil. I think we see the eosinophil a bit later because the mast cell has been activated. And neutrophils, there's many ways, there's many overlaps with neutrophils. What's important with neutrophils is timing. So neutrophils really usually happen much earlier. So I think when we go to look, at, there's both the immune response. So Dr. Cooper was talking about sort of this cytokine IL-4, which we would associate with mast cells. Mast cells releasing IL-1 and everything leads to IL-17 type response, but we're talking about stages. So we can catch myocarditis in patients at different stages, earlier stages, the stage, after the acute response going into early DCM. And we really, what about people that keep getting reinfected? So like with Coxsackie virus, you get infected every year, right? So also like influenza, you can get infected every year. And we really don't have a good understanding, even in research terms, what that means for what's happening in our heart when those reoccurring infections happen, just on a normal sort of level. And I think, we've got stages and timing with that and how the immune response changes. So, we want to get better, as Dr. Cooper was saying, better at understanding the stage that we're at and how we can intervene best. We want to stop the acute response and calm it down. We want to give therapies that will inhibit the overactive immune response, but not prevent our protection against the viral infection. And at the same time, prevent the remodeling, which is what really is leading to chronic heart failure or dilation. So really targeting those, and also in a sex-specific way. We study sex differences. There's really big differences in what's going on by sex in the immune response and the basic physiology of the heart, the immune cells, and how they're responding. So all of this, as we go forward, can become fine-tuned more, is what we're hoping, so that we can really come to a time when we can intervene much earlier and prevent progression, is what we're hoping.
Yeah, I have a comment about that. It's actually very interesting, DeLisa. I think a decade and a half ago, there were some Italian researchers reporting antihistamines for reverse remodeling in idiopathic dilated cardiomyopathy. So it's kind of looking backwards from people who progress to develop unexplained cardiomyopathies. There were some, suggestion that, a certain immune, pathway that is related to the histamine blocker actually could be influential, and that there are interesting observations about mast cells in the coronary disease and cardiomyopathy literature for some time. It's just that they are not systematically, activated. Firstly, the tryptase levels and others are actually not always up. And in fact, most of them are not increased. So I assume that even in the various myocarditis models, they are probably locally activated. Is that correct?
Well, tryptase only comes up right after early activation. So it's actually not a good measure for what we're looking at. We actually see mast cell activation during the innate immune response that critically drives the response during acute myocarditis and also during dilated cardiomyopathy. So they're actually important at each stage, but they are not, histamine is also released early, and also these mast cells differ by sex, and also the mast cells are different. So we've heard of Th1, Th2 cells, two different types of T, two different, say, macrophage subsets. The mast cells are different as well, and they differ by sex. So we really need to understand them at the stage of disease that we're looking at, and what we're trying, they play a critical role and really make a difference, whether it's going to be fulminant, whether it's going to be lymphocytic. I think whether it's the nature of the autoimmune type phase, as well as we found that giving recombinant IL-33, so this is for everybody, this is a cytokine that really we found drives eosinophilia, but also activating mast cells. And this creates an animal model of sort of like giant cell myocarditis. And really, so they're really important, I think, in all these different flavors and types of myocarditis as well. So I think it's, they're not an easy cell to study, but I think it's absolutely critical and has to do with susceptibility and type of myocarditis.
Yeah, and drugs that target mast cells obviously are very different. You're talking about doxepin, albuterol, like they're completely different classes. It's very different from the current drugs we use for the autoimmune.
Yeah. So it needs more. We need to understand it better in that relationship, but very important for pericarditis, absolutely, as well as myocardial remodeling as well.
Speaking of different stages, we have some questions that are about how long does it take for a scar to heal. Someone had asked if a scar is still on your heart 8 months after diagnosis of myopericarditis, is it considered permanent? And is it normal to have chest pain 1 month after diagnosis of myopericarditis? How long will it take for the pain to go away? Can anybody answer anything on that?
I can answer. So let me just define what we mean by myopericarditis or perimyocarditis. So you can have, as we heard from DeLisa, there's a lot of overlap between pericarditis and myocarditis. So you can get pericarditis alone, at just the outer lining. You can get myopericarditis. That means predominantly myocarditis, but maybe there's elevated troponin. Or you can get perimyocarditis. The last part of the term is the predominant, where you get elevated troponin, you get scarring in the heart, and very little pericarditis. So there's a little bit differences with that. But in my experience, the myopericarditis, on MRI, you do see the scarring, and we do follow them. And sometimes it does get better, but on repeat scans, that they often stay. So we don't know for sure how long it takes for them to disappear, but once you see them, it's pretty distinct. I should mention that the field of MRI for looking at this you need really good experts because, you know, there could be some artifacts that people are calling scarring that could be artifact, but in general, they do stay and they can for a while and then they can gradually get better. We don't know how long it takes for them to disappear or it's permanent.
Thank you. Thank you very much. There were a number of questions about that. And they questioned mental stress. Does mental stress play a role in these conditions and the healing of them?
For pericarditis? Okay, so
Or anything? Yeah.
well,
It was about pericarditis, actually.
okay, so in general, let me just go over the about the exercise and mental stress. So when we have active pericarditis, we tell our patients, and this is the biggest thing for a 25, 30-year-old person who likes to go to the gym and work out. When we see active pericarditis, whether acute or recurrent, we say sort of, you know, let the thing heal. So we do mention that. I mean, there's not a lot of data for this, but more observation. We tell patients try to keep your heart rate less than 100. Perhaps, you know, less steps. Let the thing heal. We know from experience, and we're about to do a randomized trial about exercise, no exercise and pericarditis. Now, I also tell them that physical stress or mental stress could aggravate it. So I know I've experienced where people just host a dinner party and their pericarditis acts up. So whether you're playing ice hockey or just hosting a party or walking at the airport, pushing your luggage could aggravate things. I tell them that you know, the people who do the best could take a cup of coffee and where I live in Cleveland, look at Lake Erie and look at the seagulls. Obviously, very busy people can't do that, but the more active people, it does seem to aggravate things. Obviously, this deals now with disability, medical leave. You know, I don't get involved with that aspect, but I find that the ones that could take it easier, slip away from their job for 3 to 6 months, stay on the meds. We sort of say the amount of activities like walking your dog, and people quote me on that. I just made that up, but that's the amount of activity we encourage.
Thank you, Dr. Klein, and everyone for your input onto the pericarditis questions.
One last thing, Jen, I should mention. I should put a plug that similar to the Myocarditis Foundation, we do have a Pericarditis Alliance Foundation. So that's for those people in the audience that have, you know, purely pericarditis, there is a newly formed Pericarditis Foundation called Pericarditis Alliance in the last year, and that's getting going, very, very active. There also is a Facebook page on pericarditis. I think there's 4,000 or 5,000 members, so very active community. So there's a lot of resources out there for pericarditis.
Thank you, Dr. Klein. Yes, yes, I was going to say that. Okay, now we have 27 patients and families on the call today who have had viral myocarditis. And if you are not one of the myocarditis patients, myocarditis is inflammatory heart disease like pericarditis, but myocarditis causes the myocardium, or the middle muscle layer of the heart, to become inflamed. And Dr. Tang, as a cardiologist who deals with adult patients, I will address these questions to you, but as everyone else has been adding their thoughts on these topics, please feel free to continue to do that. We have a patient who developed a left bundle branch block. I know this is more specific, but it's an electrical disturbance on an EKG, basically, for those of you who don't know. And can you briefly explain, Dr. Tang, if the myocarditis can cause such a bundle branch block, and is there anything that can be done to keep it from getting worse?
Thanks for your question, and thank you for inviting me. So I think conduction system is always a very obvious target for myocarditis. There are people who develop not only just left bundle branch block, but even complete heart block as well. I think the challenge of really pinpointing that comes down to having kind of multiple causes of that. Some people actually, develop it kind of on its own, and others actually develop it because of there's a remodeling effect. So people actually, even people without myocarditis can actually develop left bundle branch block. But when the heart gets bigger, the bundle, which is actually specialized, heart cells, do get stretched, and we actually see that improve in response in small number of patients after we ended up pacing and resynchronized the heart. But the short answer is yes, it can happen at the bundle. It could happen particularly because most of the myocarditis, as we know now, involve inferior septal region. And so that actually can develop into left bundle branch block. Leslie, do you have any other things to add? I think that's a reasonable.
Yeah. Wilson, I think you put it very well. With a specific left bundle branch block, it's not a conduction problem that is unique to myocarditis. That people with age-related changes of the heart, people with other forms of cardiac injury can have left bundle branch block. However, within the world of myocarditis, the anterior septum is an area that is often affected by cardiac sarcoid, a specific form of myocarditis. So we think of a small number of specific and treatable disorders which are within the inflammatory realm when you have a left bundle. Those are uncommon, so we don't often find them, but the pattern on MRI or the presence of extra cardiac inflammation in the lymph nodes of the chest can give you a hint about whether this is just myocarditis or another form of heart disease or a specific form. So yes, I agree.
And clinically, we don't jump to conclusion even within the first 3 months. We actually try to treat the heart. And if the heart actually gets better, there are some people, small number, but there are some people when they have significant improvement in the heart function, their bundle actually improves. So that's why in the clinical guidelines, we actually want it 3 to 6 months out to make sure that the heart is getting better. Now, most people do still have the left bundle branch block. And if that's the case, if the heart is still weak, we do think about resynchronization therapy to actually help improve the coordination of the heart between the different chambers.
Okay, thank you very much, Dr. Tang. This is probably not an easy explanation either, but we've had a question about eosinophilic myocarditis. And I know that that is very rare. But their question was, is it considered hereditary? And if it is, are there any tests that can be done to see if others in the family might develop it?
Yeah, I think, specifically for eosinophilic myocarditis, it is a very rare disease, although it is a very challenging and important diagnosis. Eosinophilic granulomatosis polyangiitis, or EGPA, used to be called Shirk-Strauss disease or syndrome. About half of the patients with that condition actually develop a cardiac involvement. And in the past, we don't have as good of a diagnostic tool, but now MRI is routinely performed in those, or even in those without known cardiac involvement, because we actually recognize that portends worse outcome and require intensification of immunosuppressive therapies. Particularly important now that there are drugs that specifically block interleukin 5 that actually is used in this condition. So clearly, I think our rheumatology colleagues who takes care of autoimmune diseases do work with us very closely. I do think that we have to kind of think broadly too, because eosinophilia it is quite common either as an infectious cause, hematologic cause, meaning from the blood, abnormalities, whether these clones are produced more than usual, or actually underlying malignancies, or actually toxins that the body has immune or allergic responses to. Those need to be clarified and detected, because clearly the treatment is to really relieve the underlying problem. If there are parasitic infections that lead to eosinophilia that involve the heart, then obviously the treatment is to target the specific pathogens. I think DeLisa wanted to say something about that.
Yeah, just to really follow from what you're saying. So in our animal model, we give the virus, but if we give recombinant IL-33, we induce this eosinophilic myocarditis. And what that means is IL-33 is usually abundantly present in cardiac myocytes at very high levels, this cytokine. So my hypothesis would really be that if there was something that could really cause damage to the cardiac myocytes, that might be a very overwhelming viral infection that was more lytic. Most infections may not be that severe, or it might be the type of virus, or maybe some other kind of infection that could be, or toxin that could cause a real, some real necrosis and death of those cardiac myocytes and release a lot of IL-33 all at once. I think you could really induce, based on this, eosinophilic type of myocarditis. So that just from research that suggests that.
And Leslie always taught me about eosinophilia in the heart tissue and what to do with it. So Dr. Cooper, maybe you can add on that too.
I would just add to what you initially said, that eosinophilic myocarditis is pretty rare, and it's really important because the eosinophils really tend to respond to prednisone acutely, as well as in more severe cases. For example, there's a rare disease called hypereosinophilic syndrome that we have drugs that treat that specifically block interleukin-5, IL-5. Mepolizumab's one of them, and they work exceptionally well, and they're very specific. We don't use those in other forms of myocarditis, but they work really well when you do need them. So it is important to make the diagnosis. It's a serious diagnosis. It's one that is difficult to make. Sometimes you need a heart biopsy, and then the treatment is very specific depending on the underlying cause. But overall, this is a great reason. If you're on the call today with the eosinophilic myocarditis question, definitely the Foundation's a great resource to get you in with the right treating physicians if that's the issue. Always glad to be helpful.
Yeah, and we're very aggressive in trying to identify, because I think the consequence of undiagnosing it is actually not good. So we do have to be very aggressive in that.
I have a question for DeLisa, who's a researcher. So this would be for the comment for the audience. So somebody gets a Coxsackie viral infection. Who's going to get the viral pericarditis? Who's going to get the viral myocarditis? Who's going to get the viral myopericarditis? Is there anything from your research that will tell you which layer will get hit?
Well, I would just say at this stage, we do see a difference in mouse strains, which is really kind of falls along more the fulminant versus lymphocytic. So the perimyocardial type of histology that we see in the heart is really more the kind of the lymphocytic myocarditis, which is most common that we see in the United States. And we really don't see it with the fulminant. So when we get fulminant, we get massive amounts of inflammation, and it is not distinctively pericardial in my experience. And so I think that that's important. And the main thing that I've, we haven't got studies on it, but kind of the observation is that fulminant cases tend to occur more in other areas in the world, more in Korea, maybe in Japan, or maybe even in Africa. And so that might be both, we think there's different viruses that are the main source of the problem in some of those places, maybe hepatitis C or other viruses and not Coxsackie. And also, we're talking about a different ethnic race background, which could also make a big difference. And what I mainly see the difference between those models is the mouse strains is whether they genetically have more mast cells or not. So some mouse strains genetically have more mast cells. They get more of kind of this Th2, but it's Th17 type response that's really profibrotic and in a sense kind of more mild in that it causes the lymphocytic myocarditis. And then we have another mouse strain that does not have hardly any mast cells genetically, and they don't produce that response. And so they respond with a really strong, we call Th1 response, where they have really uncontrolled sort of inflammation that in very high levels that's fulminant, and they don't remodel at all. You need the mast cells to remodel. They will have in that mouse heart, it can be up to 80% of the heart have inflammation. All of it will completely disappear, no remodeling whatsoever. They recover, they never progress to dilated cardiomyopathy. And interestingly, we see exactly the same thing. When I was doing my PhD, I was also studying cytomegalovirus, myocarditis, which we don't see as a virus that we think is causing problems very much, but it's completely different type of virus. It is a large envelope DNA virus. As far as viruses go, it couldn't be any different, more different than Coxsackie, which is a small RNA, an envelope. They're completely different in what immune cells are good at getting rid of them. And yet they produce exactly the same time course and the same strain susceptibility or not. So it's the immune response to the virus and not the virus itself that made the difference. And whether it progressed and had remodeling completely had to do with whether the mouse strain had mast cells or not. So it's really interesting.
And DeLisa, Jen, as we get to the top of the hour, I want to make sure that I throw one more plug in for the biobank. That what DeLisa was saying to the group about genetic background, we don't know in people at a deep level what immunologic genetic background predisposes or doesn't, and the integration of those genomic data with deep tissue studies. And that means understanding the individual cells within the heart biopsy and how those cells relate to each other. Some of them are inflammatory cells, some are myocytes, which are heart muscle cells. Others are called stromal cells, which are outside of the myocyte, like fibroblasts or dendritic cells. And there are a number of cell types that relate to each other, which have not been well characterized in myocarditis so far. The biobank under Wilson's direction is going to be studying this in part, amongst other things, to really come up with a new direction and better insights and translate these incredible scientific discoveries into clinical care. I wanted to make sure that I got that pitch in at the top of the hour before our research talk.
Thank you, Dr. Cooper. We have a question. Why do some viral myocarditis patients develop sudden cardiac death and others don't?
I guess Wilson and I could both take that. Do you want to go first?
Yeah, well, this is definitely very challenging. In fact, this is the top priority of all of us because clearly that's the most devastating consequence. And if we have any way to, predict or even understand who is susceptible, we certainly have many tools to, avert this really severe consequence. I think over the last 5 years, we have learned a lot. I think Justin kind of alluded to a little bit that there are people who have, genetic cardiomyopathies who also develop myocarditis as a presentation. We have had a lot of debates over this, at least in the adult world. I don't know in the pediatric world or not, because with routine clinical genetic testing, we are now able to identify many people who present with, ventricular tachyarrhythmias or sudden cardiac death that ended up doing genetics testing, find out many of the arrhythmogenic cardiomyopathy genes that are concomitantly present in a subset of patients. And that may kind of a seed in the soil kind of concept where there's underlying vulnerability and there's some trigger that causing this kind of, smoldering ember that causes wildfire kind of scenario. And this is kind of important because once you actually identify those who have underlying susceptibility, we certainly have the ability to identify at-risk individuals. That being said, it's also intriguing that just like what DeLisa said, some people may have kind of a much stronger immune response, that the actual inflammatory response is much more prominent. And in fact, we have actually seen in many of the Holter monitoring studies that either ventricular tachyarrhythmias or frequent PVCs, frequent ectopic beats, that is seen in many kind of patients in our electrophysiology colleagues clinics. A third to a half of people may actually have inflammation that's detectable by advanced imaging. So these are, new insights that we actually find a lot more people that may be susceptible. It's just that we didn't realize it because all we are able to find is actually when the actual manifestation occurs.
Thank you. Another question is, can recurring untreated chronic sinus infections cause viral myocarditis? Now, I know that viral myocarditis viruses are not treated by antibiotics, but someone has a question about if you have recurring chronic sinus infections, could they possibly cause viral myocarditis if they were of the viral nature?
I can take that. So a bacterial infection in the sinuses itself wouldn't give you a higher risk of myocarditis, but maybe there's an underlying reason why you have the sinusitis. And if you had, say, common variable immunodeficiency or other deficiencies in immune activation or immune, both either the regulatory or the effector side of the immune system, you could potentially be at higher risk. But again, those are a very small group of people who have inherited immunodeficiencies. But if you, the infection itself, the bacteria itself shouldn't give you itself a higher risk of a viral myocarditis.
Thank you. Now, I know that Dr. Godown spoke a little bit about pediatric cardiomyopathy, but we have a patient in Europe who is asking questions about atrial fibrillation in patients with cardiomyopathy post-myocarditis. So can you speak about medications utilized for AFib, specifically amiodarone they were asking about, and any potential long-term side effects that you're aware of? I believe this was a younger man that the question came from.
I would probably defer that question to some of my adult colleagues.
Yeah.
In fact, atrial fibrillation is pretty rare in young people, and so we do not see it very often at all.
I think this is like a late teen, probably adult-sized patient.
So obviously, atrial fibrillation is a very common disease as people age. In fact, Dr. Klein's early career talked a lot about how to tackle it early and prompt. But we have obviously drugs, and amiodarone does have a lot of long-term side effects to the liver, to the thyroid, to the lungs, to the eyes, and to the skin. And so we like to kind of minimize it at all costs, except that sometimes when the heart is weak and when there are others is refractory to other medications, we kind of needed to use it. When patient doesn't have a structural heart abnormality, if the heart function is normal and not a lot of scar, we actually have a larger array of antiarrhythmics. But most of the time, we actually control the rate and revert the symptoms, the rhythm back to the normal sinus rhythm. And our electrophysiologic colleagues have actually developed many excellent techniques now, and the AFib ablation procedures are getting more and more refined and provide a much needed relief. So this is a long-term multidisciplinary kind of approach to do that.
Thank you. I seem to be hitting you with all these difficult questions, not very straightforward, simple questions. I'm very sorry. We discussed chronic pericarditis a little bit with Dr. Klein earlier. We have some patients who are concerned about the potential of chronic myocarditis, that they've had myocarditis a couple of times, or they're worried, could it come back? Could somebody explain chronic myocarditis, please?
Sure. So clinically, again, most myocarditis recovers over a time course of weeks to months. And then there's a small group of people who go on to have more chronic heart dysfunction. Sometimes there are arrhythmias, but mostly it's heart dysfunction in the form of symptoms and decreased heart pump function. In that setting, there's several reasons. Some could be scar that was formed at the time of the initial injury. And some could have ongoing inflammation. Our colleagues in Europe have spent a great deal of effort defining the histology and the immunohistology of that chronic inflammation called inflammatory cardiomyopathy by some. And that may have its own specific treatments. So the short answer is that it's not histologically always the same as acute myocarditis. Clinically, it's usually present with symptoms, and they would be extending more than 6 months after initial myocarditis. I hope that's helpful.
Are there treatments being studied to treat chronic myocarditis, such as there were for chronic pericarditis? Are there studies being done, do you know?
Yeah, so there are several papers that have come out of our European colleagues' labs and clinical facilities in Rome, in Northern Italy, and in the Netherlands, looking specifically at azathioprine and prednisone in combination given for chronic inflammatory cardiomyopathy that doesn't recover after acute myocarditis. And those have been positive studies. There are, in the chronic setting, other people have looked at antiviral strategies, but those trials have been largely negative or neutral. Wilson, did I miss anything on that?
No, I think there's some small studies here and there about various, dietary lifestyle and also some off-label drugs, but the amount of clinical trials in myocarditis is actually small, in part because we don't have a unified way of identifying the patients, as well as the large majority of patients actually do recover spontaneously. So it actually is a challenge in designing these clinical studies.
Speaking of difficulties in diagnosing them, we have a question from someone. Do you think there is any plan being made or thought about for having a standard practice for primary care physicians to screen people during general checkups, particularly children and young adults, for current or previous myocarditis symptoms?
I think that's going to be really challenging. I think it's a great question, but the truth is that myocarditis is still a very rare diagnosis. And so the chances of picking up something in routine screening is just going to be really challenging.
Yes.
And so I suspect that won't be the case. Clearly, physicians are always attuned to things. And so if there's clinical concerns, but there wouldn't actually be a great screening tool for myocarditis that I can think of. Leslie, I don't know, what do you think?
I'm sorry, was the question broad screening for myocarditis?
Yes, more specific for children and young adults, but yeah.
People tried looking for troponin levels, which is a blood enzyme, which it's a protein which goes up in cardiac injury in children who had fevers, high fevers. And there was, I think, 6 out of 1,000 were positive. So it's screening with EKGs or with blood tests to look for cardiac injury. Really, in a broad population, doesn't give you a very high yield. I think that, again, I'm not the pediatrician in the room, but typically I'm driven by symptoms. So, and symptoms can be difficult in young children, of course, but if you're having chest pain, if you're having otherwise unexplained trouble breathing, then there's a symptom that you're focusing on, as opposed to a non-specific viral illness or fever. That might be one way to refine when to consider screening.
Yeah, and a big issue is even if you do advanced imaging and others, whether those features really have long-term consequence or not. I think there was a lot of questions in the chat about COVID and COVID myocarditis. And early on, when we have several of these MRI studies on post-COVID patients, we were very concerned with both the troponin as well as the MRI findings. But then as we continue to treat and also to routinely screen, we find that the actual incidence is much lower So, and those are very non-specific features. So that we are still kind of struggling to because if you test some things, there'll be a subset of patients will be positive, whether, you know, any treatment or whether their natural history is definitely different or not. We have to be very careful.
Thank you. We have some post-COVID myocarditis questions and questions about the COVID vaccine that we can move on to. One question is for the panel: how normal is it to have myocarditis symptoms even after having a normal echo and repeat labs post-myocarditis? And what is known about the recovery of cases of myocarditis that is due to COVID-19?
Any of us could take that, I guess. So what Wilson was getting at earlier is that the initial concern about MRI findings in people who had had COVID with or without symptoms turned out to not be associated with much myocarditis on tissue histology. And that was raised two questions. One, what were the MRI findings of any clinical significance? Did they mean that you would have a higher risk of death or transplant or any other kind of arrhythmias, or should it change your treatment or behavior? I think that question for people who are asymptomatic with MRI findings after COVID, if you were, say you were a professional athlete or you were in the Big Ten and had an MRI as part of your routine evaluation, then I don't think we have the answer to that. We haven't had a lot of reports of sudden death or in athletes in that setting, but I think there's also been a pretty standardized recommendation to avoid competitive sports for a period of months. So that is yet to be finally determined in the long run, at least in the subacute and acute setting. The second issue it raised is, what's the mechanism? That why would you have MRI findings if there's no myocarditis? And that's an area of intense research here and elsewhere. Cedars-Sinai in Los Angeles, others have been focusing on this and producing some really interesting novel data about the mechanisms of potentially changing MRI tissue features or the stiffness of the left ventricle after COVID. So that's one topic. The second was about long COVID. What if you have symptoms of chest pain or shortness of breath 6 or 12 months after COVID? And we know a substantial number of people, even those who are young and healthy, will have some symptoms along those lines in the long run. And again, a lot of research is going into this. Today, I think we know that it's multifactorial. Many times it's related to the deconditioning of the acute illness, and it's related sometimes to some lung injury, and maybe sometimes to some stiffening of the ventricle and some changes in pressures with exercise in the heart. But those are not the majority. That we're figuring out when each is important, and there are ongoing research studies to the mechanisms of symptoms in long COVID. Some of it's immunologic, but we don't know exactly how much. Anything to add for the other panelists?
Well, I think also the symptoms after vaccination itself may mimic myocarditis, but you know, if you think about it, we are injecting intramuscularly some novel, substance that ended up, the purpose is to activate the immune system to go against the virus. And of course, at the arm, it actually drains to the different lymphatic and lymphoid tissue. So we actually do see patients, even independent of COVID vaccines, that they have some, chest symptoms. And that has been actually reported in mammograms. For example, they may actually see some, changes in the mammograms. Many women in screening actually found some shadows. So I don't know if the heart itself has anything to do with it. I just think that a lot of symptoms may not actually be, bona fide certified myocarditis, but certainly in the MRI studies, we certainly saw that. So the CDC actually have very strict criteria on probable versus definitive myocarditis. You have to have the criteria for MRI and troponin to define myocarditis. And clearly the data so far has been mainly on the young adults. Dr. Godown may actually comment on that, young adult males, which is actually consistent with many of the other vaccines that we see. And they have strict guidelines about if you have myocarditis, that should be resolved before you think about the second dose. So far, I think the third dose has been much more tame in its response, at least from the reports from Israel. And of course, the Moderna just approved its half dose. So I do think that if there is complete resolution of the symptoms and all that, just like how we release people back in athletic activity, they are safe to get their second or third dose.
Yeah, I can speak a little bit about the post-vaccine myocarditis. So it's actually a pretty recent report that young adult males after the second dose of the Pfizer vaccine basically can develop evidence of myocardial inflammation. The interesting thing about it is there's only a handful of cases. It was still really, really rare, but it was the timing of it. So the timing occurred a very specific time interval after the second dose of the vaccine. I think a really important point of that is in a rare event, it's really difficult to prove causation. So even though the timing is very suspicious and clearly you start to wonder, is there an association there? We can't actually prove that the vaccine caused the myocardial inflammation. The other point is that out of the millions of people who have gotten the vaccine, this is just a handful of patients. So the risk is extraordinarily low to develop myocarditis after the vaccine, at least based on data from the vaccine adverse event reporting system in the US. The other important point of this is that all patients tended to have a really pretty benign course. So many of them required inpatient admission, but pretty much all of them recovered very quickly and did not appear to have any major sequelae, at least in the short term. We don't really know what the long-term outcome is going to look like for those patients. Was there any damage to the heart during that process? And that's just things we'll have to figure out as we move forward.
There was a question about someone who developed myocarditis after a COVID vaccine, and they were wondering if they should avoid other vaccines for fear of adverse reactions.
I think that's a really challenging question. And I'd probably ask you to speak to your physician because they're going to know your specific situation the best. And it's hard for us to give specific advice related to that.
I'd agree that, currently, if you had a vaccine reaction to a COVID mRNA vaccine, I think there's a waiver for second or third vaccine. But if it's say you're talking influenza vaccine, right, after a year after COVID, I don't know that there's cross-reactivity. So, or there's data. I don't think there is data to say that you should avoid other vaccines. And by the way, vaccines are incredibly effective at preventing disease at low risk. So the reason we don't take care of polio in this country very much is because of polio vaccines, right? So we need to always keep in mind that these, despite the very small risk signal in young males, it's still, even the competing risk against the virus itself is always in favor of the vaccine, right? So pretty much, at least the data that exists, I have to say, I've not seen any like children under 12 data, and even the 12 to 16 is pretty limited. I don't know. I've seen much of that, but I've seen the that's published. But pretty much everyone should get the vaccine.
I agree also. So if I can just chime in a couple of things about this field. So I run a big pericardial center clinic, and every week I see 2-3 patients now more about the vaccine, whether I should take the extra dose or from the COVID. So first thing about the COVID and the mild pericarditis that can happen, as Wilson and Leslie mentioned, the MRIs were overcalled. So in other words, we reviewed outside MRIs that claimed that they had myocarditis, and we looked at our stringent criteria, and it's basically overblown, and the criteria were very loose, and that's why it was called myocarditis. That's the first thing. So it is quite confusing out there in the community. The second thing is, and the other thing is, I do see a lot of patients that have they've had COVID and they have chest pain, and we can't find anything. and many cases like this. So we attributed this maybe to long COVID, and we don't know exactly what that means, but we can't find, they're coming from out of country to see us, and their MRIs, their echoes, all their bloods are normal. And the other thing is about the athletes, as Leslie mentioned. This is always a very big thing. We're seeing a lot of Division I athletes that either from the COVID, getting COVID and having some chest pain, you don't find much, or now after the vaccine. So it is a controversial area. I think more research is necessary, but I think it favors getting, in general, getting the vaccine versus the worry that you're going to get a myocarditis. If you're 19 years old, 20 years old, you can maybe pause and think. But if you're 50 or 60 years old, definitely take the vaccine.
Thank you.
I'm going to say something really have no data to support, but I've been asking myself when I got the vaccine to not do strenuous exercise for a week. I don't know if the panel would agree with that, because if you think about it.
I took one day off, Wilson, from my vaccine. I think that tells a lot about our personalities.
So I guess the one thing I would say just with age is that also we see that myocarditis does occur in younger, individuals, usually 50 or younger. So also, that's an important factor in, as you're getting older, that your chances of getting myocarditis are much, much lower. So much less concern regarding that.
Although I think Allan and Leslie point to the fact that myocarditis itself is a manifestation of COVID, and it's much higher than the vaccine itself. Basically, anything that you worry about the vaccine, the COVID itself is much worse. So I think that's a good summary of that.
So another thing that's happening, I have a lot of calls in from the CDC questioning about patients, because patients, maybe on the audience out there that had the vaccine, they'll call the CDC, and CDC is investigating. So I have literally 5 to 10 calls coming that have to follow up with the CDC, and they want to track. A lot of patients are claiming that they, from the vaccine, and a lot of the time periods are way off. Like you're talking about 2-3 months later, which doesn't make sense. It's possible, but doesn't make sense. So there is a lot of, obviously on the call, there's a lot of interest about this. And I have a specific patient that has pericarditis, and he has vascular issues. And the only thing he's attributing is it's from the vaccine. And it's hard to know exactly why he has that, but a lot of interest and a lot of investigation still needed.
And just to add for everybody in the call that the vaccine and COVID itself did not stop any of the other background rates of myocarditis. So when you think about although, even in the highest frequency population, 16 to 19-year-old males in Israel, it's 1 in 6,000 is the rate for COVID vaccine related symptoms of myocarditis. That's a low number. The background rate is still there. So you have to say, what is the excess rate over that background? Those competing, that analysis has been done in a couple of a study from Portland, Oregon, a study from Israel, as well as the competing risks with the virus, which is a separate question. But again, to put it in perspective, we still have all the other causes of myocarditis in the background. And they can occur after vaccines. The vaccine doesn't protect you from Coxsackie virus.
Correct. Not to stop these questions from happening, but we do have a couple of more areas that we have to touch on, and we only have a half hour left to do it in. We have a lot of questions about giant cell myocarditis, and while giant cell myocarditis is extremely rare, we have 21 survivors on the call today. 17 adults, 1 teenager, and 6 of these patients have had heart transplants. That's an amazing number to have all together in one place today. Dr. Cooper, since you're the specialist here on giant cell, I'll address these questions to you, but once again, panel, please feel free to join in. We have someone that developed giant cell after a vaccine. Should people who develop myocarditis post-vaccine be biopsied for giant cell? This was her concern.
So this is a patient who previously had giant cell myocarditis and
She
then
developed it after a vaccine. No,
Okay.
she had a vaccine, developed giant cell, and she sees people who now develop myocarditis post-vaccine, and she's wondering, should we be biopsying them for giant cell?
The short answer is almost all vaccine-related myocarditis is monophasic and self-limited. It's a relatively mild disease, more than 80% of the time. So no, the short answer is that giant cell myocarditis is still rare. It's still rare. And the criteria that we use for biopsy, which include hemodynamic compromise, meaning low blood pressures that require medicines by vein, or unstable ventricular heart arrhythmias, or high degrees of heart block in the conduction system, those are still worrisome features regardless of whether you have a vaccine, and should probably be the primary determinants of whether you get a biopsy. The presence of a vaccine itself is still, the vast majority of these cases are not fulminant. Not all of them. There are occasional ones that are fulminant, but I would say more than 80, if not 90%, are monophasic.
Thank you. One of the patients was wondering, what are the effects of COVID on giant cell myocarditis patients?
That paper hasn't been written. I don't think that there is a known interaction. I think that if you had giant cell myocarditis, either with or without a transplant, you may be on immunosuppression. And so the effectiveness of a vaccine in the context of multi-drug immunosuppression could be lower, and the relative severity of COVID might be worse. You could hypothesize that, but I don't think that's been studied by anyone systematically. You just extrapolate from other immunocompromised populations. But and all people who have heart failure, including those with giant cell myocarditis, would benefit from a vaccine, I think.
Okay, so there was another question that asked, since immunocompromised patients who get the vaccine don't always develop antibodies, or a lot of them anyway, what do the experts say on these patients taking the COVID vaccine? I think you might have answered that, but.
I kind of split this answer with the other panelists. We have not been routinely checking IgG titers in people. I don't think that's a common practice, but I'd ask if there's any different management of people with immunosuppression.
Obviously, I manage a lot of transplant patients, and we also have not routinely measured, in part because the antibodies that is commercially available are not indicative of the immune responses, as far as we know. The ones that has been analyzed are much more comprehensive, the ones that have been studied in various institutions. We do know about half of the people who are post-transplant do have response, and that's why back in the summer, several European countries started the third dose for the immunocompromised patients, either those who have underlying immunocompromised problems or post-transplant, or those who are receiving immunosuppressants. So I think the U.S. obviously, approved the booster shot way early. I think about a month or two ago. We do see them coming during the waves to have COVID, but now obviously with various drugs like monoclonals and others, we are able to at least tackle those with COVID infection. This is still out there, and immunocompromised patients are at risk of developing COVID.
The same thing in the pediatric population. So we're universally recommending the boosters, and we are not checking IgG levels.
If I can plug in about pericarditis patients, so often they're on immunosuppression as well. It could be on rilonacept or steroids. So I do recommend the vaccine or the booster, but I tell them that if they're tapering their meds, they shouldn't taper. So as long as they're chest pain free and they're on a stable dose of their medicines, they could consider the vaccine. But if they're having a flare, recurrent pericarditis, don't take the vaccine at that moment. Same with the flu shot. So there are some recommendations. And also, as the others have said, the immunosuppressed may have less of a response. We're not measuring IgG levels, but we expect it's a little less immune response.
We have a patient who had developed giant cell in 2009, and when she had been diagnosed, they told her there were 60 known cases. And now she hears that there's about 300 known cases. Do you know how many cases, Dr. Cooper, are worldwide, and is it getting diagnosed more often nowadays with the awareness out there?
I don't have any global data on giant cell myocarditis from any systematic reporting. I can tell you I hear of a new case once a month, which is the same rate as 10 years ago. I think that there is a heightened awareness of myocarditis in general. I think with MRI and with the educational work of this foundation, more physicians are thinking of myocarditis, and the diagnosis in general is increasing. But giant cell specifically, which is again a rare form of myocarditis, seems to be about one a month. And I would say that 3 or 400 is probably still the range that I would estimate, or perhaps it's in the 400 range by now.
Okay, thank you. Is there more recent research being done on treatments for giant cell?
You know, yes, I think that we published an update of our guideline our expert opinion recommendations in February, which brought up to date a number of the drugs that we use in the management acutely of giant cell. And that was because some of the medicines we used 20 years ago, like Muromonab CD3 called OKT3, we don't use anymore. So we needed to see what is now available in today's armamentarium, anti-thymocyte globulin, a drug called Campath that were included. So yes, we've updated that this year, and that's out in the literature in a number of areas. The second is on mechanisms. Really nice study from Vanderbilt University came out in Circulation Research maybe 3 months ago, looking at patterns of different cellular activation in the heart. And they discovered neutrophils, interestingly, and neutrophil nets were important. And that may turn out to be an important new direction, I think. But that still remains, those were done in human tissues, a small number of human tissues, and I think they need to be replicated. And
Okay.
It was a good paper, though.
Thank you. Now, we have a patient who was concerned. She's had repeated flare-ups of giant cell post-transplant. And would she be a candidate for another heart transplant? And why exactly does giant cell reoccur in a transplanted heart?
Wow, those are great questions. So we know that about 20% of patients who have had a heart transplant for giant cell myocarditis could have histologic recurrence. And the series from Cleveland Clinic a number of years ago, Montreal Heart Institute, more recently, Cedars-Sinai had a paper, and we have our big series, all looked at post-transplant recurrence rates and management. And so the short answer is that although there's about a 20% rate of recurrence, most of those are asymptomatic. They are incidental findings on a biopsy that respond to a bolus of corticosteroids and a taper, and they don't affect the function of the heart post-transplant. So that's simple. Now, the second question, which is much more complicated, are you specifically a candidate for heart transplant? Involves a lot of other knowledge that I couldn't really answer. Wilson, I actually have not had anyone require a second transplant that I'm aware of.
Not for the purpose of giant cell. I think most of the retransplant really comes down to either primary graft failure or most commonly coronary vasculopathy, which is kind of the inflammatory changes of the coronary vascular tree as a whole. And now one can argue that, that may be another a form of immune dysregulation, but not in the same manner that we see in giant cell myocarditis, where rapidly progressing cardiac dysfunction and arrhythmia with the presence of giant cells. So we do see B-cell myocarditis, or cell-negative myocarditis and primary graft failure, but not necessarily giant cell as the reason of retransplant.
Correct.
Dr. Fairweather, we have some research questions that we wanted to ask you before Damian gives his research explanation. Is there anything that can help a person with myocarditis heal, such as diet, probiotics? I know that you've spoken about mitochondrial function, and so they were asking about mitochondrial function support supplements.
Damian's going to be speaking more about mitochondria. We're still in early days of understanding that, but I would probably say, that couldn't hurt, things that are available out there. I guess one thing that we recently published was that bisphenol A exposure, BPA, in plastics, we found that when we exposure to that with the virus infection really caused activation of mast cells and aggravated disease in the animal model. So that was something, I think that a lot of data is now coming out that there is a relationship with increased exposure to plastics and BPA and other plastics with being harmful for a number of diseases just in general. So I think that's one thing that if we can reduce our exposures, it's probably a good idea just in general. But it was very interesting in this study because we know that sex differences are really important. BPA and other plastics are endocrine disruptors, and they're able to go in and bind to and disrupt our natural estrogen receptors. And that's really important. And those estrogen receptors are really important in mediating protection against heart failure. And they're very important also with mitochondria and mitochondrial health. So both of those elements are important. So anything that can disrupt that in general is not going to probably be good for your health for a number of diseases. And we were able to just look at that interaction with a viral infection, showing that could play a role. As far as I would just say in general, anything that's to reduce mast cell allergies or activation is probably going to be a good thing, just as a background thing to do for your health. Otherwise, I think the problem that we have is that many viral infections, common ones like Coxsackie that you catch every year, influenza, can cause myocarditis. What we don't really understand at the moment is why with these common infections where so many people, everyone is getting them, why only some people then develop disease. And whether maybe many people develop very mild disease and we don't ever really notice it, we don't have symptoms, might be another possibility. But that's, those are questions that we're still trying to understand better with research. And we think many different things can cause inflammation in the heart. It just might be that the immune system, it's really good at going in and getting rid of infections or damage and then healing on its own. So anything that's going to give you, promote your natural immune response, like good sleep, exercise, all the things that you've heard, healthy diet, all those things are going to be good at helping your immune system to be able to fight off infections and be a healthy immune response. And then we'll try to understand why some people have an overreaction to common viral infections.
Thank you very much for that. Now, before we submit any other questions that came into the chat room for our doctors, I'd like to present our myocarditis research PhD candidate, Damian DeFlorio, to present a synopsis of his research that he is working on at Dr. Fairweather's lab at the Mayo Clinic in Jacksonville. Well, not yet, but Damian DeFlorio, you are welcome to present your research, please.
don't think we can hear you, Damian.
Yeah, he's
He's just fixing that, I think.
not on mute. He's not on mute.
Yeah, he's checking his.
He's checking his
Okay,
connection.
can you hear me now?
Yes, now I can hear you.
Okay, sorry about that. Thank you again for the opportunity to speak today. Can everyone see these slides okay?
Mhm. Yes.
Awesome. Great. So my name is Damian, as Genevieve mentioned, and I'm a PhD candidate in the lab of Dr. DeLisa Fairweather. And today I'm going to talk to you about two of our research projects that are looking at mitochondria in the context of myocarditis, and how mitochondria not only affect the function of the heart itself, but can also influence the immune response during myocarditis. So a lot of you might know some of these statistics already, but there's about an estimated 3 million cases of myocarditis diagnosed in 2017. Myocarditis is the third leading cause of death third leading cause of sudden cardiac death for patients under 50 years old, particularly males. And there's a sex difference in the prevalence of myocarditis that's about 3.5 males to 1 female. And in the US, primarily myocarditis is caused by viruses that localize to the heart. And we're going to skip right into mitochondria. So many of you have either seen something like this that looks like mitochondria, some kind of cartoon before. But mitochondria are actually these very complicated networks in the cell that are constantly interacting with each other. And they can take on a bunch of different morphologies. So down here, I just have some pictures of mitochondria in red right here. And these cells and these little blue spots are the nuclei of the cell, so parts that contain the DNA. And you can see in these two different drug treatments that we're giving to these cells, we actually changed, not us, another group changed the morphology of the mitochondria, and that drastically changes the function and how they're able to effectively communicate with each other. But why are mitochondria important? Well, they make this molecule that's called ATP, which is sort of the energy currency of your body. And for this reason, mitochondria are colloquially referred to as the powerhouse of the cell. You might have heard of that before. And why are they important for the heart? Well, the heart is constantly pumping, right? And so you have these huge cardiomyocyte heart cells, and they're actually packed with mitochondria because there's a lot of energetic demand for the heart. And just to give you a broader scale of like how really important mitochondria are, there's about 10,000 mitochondria in each heart cell, and you have about 2 to 3 billion cells in a human adult heart. And so that makes for about 30 trillion total mitochondria in the heart. So this organelle, this little energy-making system, is super, super important. And so we began looking at sex differences in how mitochondria affect viral myocarditis in our animal model. And the way we do that essentially is we infect some mice with either Coxsackie virus or a saline control, and we are able to take out the messenger RNA from their heart, which is the molecule that tells the cells which proteins to make. From there, we can do some genetic sequencing and a lot of math, and we're able to then use math and previous information that was published to figure out pathways, which are basically a set of instructions for a certain set of molecules in your cells to do a certain function. And so what we find is that our infected female mice, which have less severe disease, are taking a lot better care of their mitochondria. Particularly, they're maintaining mitochondrial homeostasis better, which means they're just making sure nothing drastic changes. And they're producing a pretty robust antioxidant response. And so this data suggests that females might have better mitochondria. And we're not trying to suggest that. We are saying that females have better mitochondria than males, especially in the context of myocarditis. Now, jumping into exercise, and I'll talk a little bit about mitochondria here as well. So it's actually been about 40 or 50 years since exercise has been very well studied in the context of animal models of myocarditis. And so a couple years ago, we actually generated this new animal model of exercise induced sudden death and heart failure in these animals. And so you can see here this little treadmill that we have the mice run on. And essentially, every so often, we increase the incline of the treadmill by cranking this motorcycle jack right here and increase the speed as well. And we do that until the mice are exhausted. And then we look at the actual functional capabilities of the hearts using echocardiography or ultrasound. Now, traditionally, animal studies of the heart have been mostly focused, but not necessarily limited on looking at the left ventricular function in this particular view of the heart. This is called the short axis plane or the short axis view of the heart. So you're looking like sort of up the ventricle right here, and you have the two little papillaries. Essentially, these lines that we're drawing on these different parts of this image down here tell us about the function of the heart. But the issue is that this method isn't particularly sensitive, so we can't see very small changes in cardiac function using this. And so what we utilize instead is this method called strain echocardiography, which you might have heard of, or some of you might have had done before, where we're using a software to track the movement of the walls of the heart. And this can give us very detailed information about the function of the heart throughout the contraction cycle. And so what we see in this animal model is that the mice that we exercise compared to the mice that don't get any exercise actually don't have any differences in ejection fraction after exercise. But what they do have a big difference is there is a value called global longitudinal strain. And essentially, global longitudinal strain is looking at the ability of your heart to be elastic throughout a contraction cycle and make large movements that pump and push the blood out of the heart into the rest of the body. Additionally, as well, all these little yellow dots you're seeing right here are represented by these blue lines here in this next page. And so because these blue lines are spread out, we're able to tell that this heart is not very good at contracting synchronously, meaning that it has some sort of issue probably with the conduction system, either because of cardiac damage or because of the immune response is interfering with the conduction system's ability to tell the heart when to pump. And so this is a new model that's sort of crucial for our understanding of exercise here. In addition to some of the normal echo parameters that I just showed you here, we're also doing a lot of work with advanced cardiovascular imaging for animals, so looking at things that are looked at in humans. And this is brand new. This is what's called 4D strain echocardiography. And essentially what this video is an image of the left ventricle of a mouse contracting. And from here, we're able to get even more information than we did previously on that last slide, because we're looking now at the contraction of the heart using a 3D model in 3D space. And so this is as close to cardiac MRI as we can get without actually doing it in mice. And it turns out when you compare the values between cardiac MRI and this particular type of echocardiography, that they're quite close, actually almost indistinguishable. So this is a very accurate and novel tool that we're using to understand heart function in myocarditis. We also isolated the mitochondria of the patients that we were looking, or not, excuse me, we also isolated the mitochondria of the mice in this study. And we looked at their size, because size is a very good indicator of mitochondrial stress or damage. And so we see here that when we exercise the mice with myocarditis, their mitochondria gets smaller, which means that they're being stressed out more. And we believe this is due to increasing the energetic demand. The body is trying to make more, the heart cells are trying to make more ATP, make more energy. And in order to do that, mitochondria divide so they can make even more mitochondria. And this is also indicated by this protein as well that goes to the mitochondria in the heart after exercise. It's called DRP1. And so this is the protein that basically causes the mitochondria to split into two. Our collaborator was studying heart cells in culture. And one of the things he observed was that not only did Coxsackie virus, which is the virus that we use to study myocarditis, localize to mitochondria in the heart, but they were also escaping in these little, what are called vesicles, which is just a little piece of cell, of the inside of a cell that got spat out. And so we believe that this could be a new way that the virus is sort of hijacking the heart and hiding from the immune system. And so here are some fluorescent microscopy images of these blue and green dots right here are just the virus, and then these red dots are mitochondria. And so when you put those images on top of each other, you can show actually, and what is being shown is that the virus is inside of these mitochondria that are escaping from these cells. And so what we believe is happening is that upon Coxsackie virus infection and some other viruses as well, these viruses are going inside of mitochondria and then being spat outside of heart cells and sort of really interacting and making your immune cells sort of angry and causing an increased pro-inflammatory response, which causes even more damage. And we recapitulated this in our animal model. And so this is the first time that we've observed these types of particles that we're calling mitopods in vivo, so in a living thing rather than just cells in culture. Now, to give you an idea of scale, a heart cell is about 100 microns. These mitopods are about 0.1 microns. So these are really small. And to look at these, we have to use advanced microscopy methods that are called super resolution. And you can see those in these pictures right here. And each of these dots represent an individual molecule of the particular proteins that we're looking at. So the blue dots that you're seeing right here are a marker for the outside of mitochondria. The pink right here is showing that the virus is inside these vesicles. And then the orange here is showing that we also have the inner parts of the mitochondria in these mitopods as well. And lastly, we did some genetic testing just to prove that there is virus inside of those mitopods. And so these MPs right here, this is showing you the amount of virus that's in these things compared to the amount of virus that's in a mouse heart with myocarditis and in a mouse heart without myocarditis. So lastly, we wanted to show that these things can interact with the immune system. And so the blue dots here are these mitopods, and these orange cells that you see right here are called macrophages. They're just immune cells. And so what this is showing is that macrophages can actually eat these things, these mitopods, and respond to them in culture. And just to finish this off, I have a nice little 3D image of the cell that shows the little blue mitopod dots inside of these macrophages right here. So with that, thank you very much for your time. I really appreciate it. And of course, none of this work is possible without the rest of the lab, who are a massive help. And of course, we need to thank our clinical collaborators and the funding that allows us to do this research. So thank you.
Thank you, Damian, for that wonderful information on your research that you're working on. We really appreciate it. We love young researchers in myocarditis. Thank you so much for sharing that with us. Now, we do have a few more questions. I know we only have a few minutes left.
There was one chat just saying how to describe that in the simplest terms. And I think it basically is, it provides an explanation for how viruses are really going to our heart, because viruses go there to hijack the mitochondria and use their energy to make more viruses. And we've really then found a reason why they would disrupt our heart function, as well as activate the immune response, so that we would have inflammation come to the heart. And so that's kind of the most basic summary.
Okay, thank you. There was a question about mammograms after vaccines, the COVID vaccine in particular. They wanted to know what changes you were seeing. I had heard that there were inflammatory changes that could have been misconstrued as abnormal mammogram, but maybe you could expound on it more. Anybody?
That's pretty much it. I guess mammograms are like X-ray images, so obviously they're non-specific. So when they see some shadows, obviously they, due to maybe, you know, the lymphatic system being really overshadowed the entire mammillary glands, it does provide some confounding. And so I think most imaging centers have been very careful about it. They don't routinely biopsy them, but they do serial measurements just to make sure that they are following, because if the inflammation subsides over time, that would actually go away.
So is there a period of time that you should wait for a mammogram after you get your vaccine? I was told personally to wait like a few months afterwards, just to make sure that any inflammatory changes might have gone away that wouldn't be misconstrued as being the wrong thing. Is there a set amount of time?
That's a logical recommendation. It's not based on science, but it's based on what we know about the natural history of how vaccines work and what inflammatory response we have. So I think it's a sound recommendation. But that being said, we are cognizant that during the COVID era, many of the screening tests have been delayed, and that actually delayed the diagnosis of true cancers. So I would you know, it would equally important that people follow up with their mammogram and cancer screening, because it's still one of the top killers of you know.
Okay, thank you. There was a question that came in about black mold as a cause of myocarditis. Are there any studies about that? Do we know anything about black mold?
No, I haven't heard of any research studies about it.
Okay, thank you. Let's see, there was this is a little different. I've never heard of this, but is there any studies to support visceral organ massage in the healing of myocarditis? I'm only asking the questions.
I mean, I think early on, DeLisa was trying to explain about the different, you know, things that a lot of people were trying for myocarditis. Obviously, that's in general for most Western medicine when it comes to chronic inflammatory disease. Many of us, and I can't speak of the others, but you know, do welcome, you know, various kind of attempts to alleviate when traditional medical therapies are not effective. That being said, many of those are not regulated. We don't know what they do, and it sometimes can be dangerous. It can actually make worse problems. I think there was a question early on about probiotics. I mean, there is some data suggest that gut microbes have something to do with, you know, triggering a smoldering mild inflammation, except that people don't recognize that probiotics in an intact gut microbiome, not a disease microbiome. You know, the probiotic strains actually all come back out. So I think our bodies is very good at keeping the ecosystem within the gut. And so many of these therapies are not well studied. In fact, those who are rigorously studied have not actually shown consistent benefits, at least in the heart failure literature. So, I mean, caution is warranted in a lot of these things in general. I would say regular healthy diet and lifestyle is key. Anything that humans have made, we have the journey of the promise of them being helpful, and then the disappointments in many of them having unexpected effects. So be very careful about what you hear about.
Jen, I know we're at the top of the hour, Jen. I want to make
Yeah.
sure I get one word in for
Sure.
all the people who've had myocarditis on the call, which is that we have an active research study. Candace led this with Dr. William Bobo at Mayo, studying anxiety and depression in caregivers and the social impact of myocarditis. On our website, and I believe also on the social media platforms that we have, there are ways that you can just click to connect with the study coordinator and sign up. It's a survey. It's just a survey you can fill. It's a red cap survey online. I encourage everyone who listened today who's had myocarditis to please, and correct me if I'm wrong, Jen, I believe that there's a link that we have on our website that people can click on to get the information.
Yes, there
And
is.
then, so I just wanted to make sure I got that word in for that, and keep your eyes open, because there will be opportunities in the future as well to help us learn more about myocarditis and its impact on people. And I
Thank you.
also personally want to thank Wilson and Allan and Damian and Justin, and just from me personally, I just want to say thank you for taking a couple hours of your Saturday morning here. I know it's time away from other activities, and I appreciate it.
Thank you, Dr. Cooper, and thank you to all our specialists today for giving of your time and knowledge. And thank you to our audience of patients and families for your interest in myocarditis and pericarditis. And we hope that you learned a lot today and that you have an enjoyable rest of your weekend. Thank you so very much for joining us. This will be posted on our YouTube channel probably sometime next week for those of you who want to review it or have not maybe had someone that could join us today and wants to just hear it. So it'll be on our YouTube channel at the end of the week next week. Thank you all again. Have a great weekend.
Thank you.
Bye.
Bye.